The topic of today's lecture is Sjogren syndrome. So let's get on with it. Sjogren syndrome is described as a slow, progressive, inflammatory autoimmune disorder. In this disorder, it is categorized by two things. One, by the infiltration of lymphocytes inside the exocrine glands. The other is the hyperreactivity of the B lymphocytes. Now, the infiltration of lymphocytes inside the exocrine glands in question are two. One is the lacrimal gland, as you can easily see here on the eye. The other one is the salivary glands. Now, salivary glands are divided into three separate glands. The largest of them is the parotid gland. Then we have the submandibular gland and the sublingual gland. Now, all of these three glands are affected in the Sjogren syndrome, that they are infiltrated by both B lymphocytes and T lymphocytes. And along with this infiltration, we also have the hyperreactivity of the B lymphocytes, or in other words, B lymphocytes start to produce autoantibodies in large quantities. Now, these antibodies are secreted against certain both cytoplasmic and nuclear antigens, which are called the Rho and La antigens. And against these antigens, the antibodies that are produced are called the anti-Rho and anti-La antibodies. Now, anti-Rho and anti-La are also called the SSA and SSB antibodies. Now, because of this infiltration, these glands lose their exocrine function, that is, the secretion of their particular product. So, when they lose their ability to secrete, this results in characteristically two scenarios. One, we have the dryness of mouth, or in other words, it's called the xerostomia. And the other condition or scenario that we usually get is the dryness of the eyes. Now, this dryness of the eyes cover the whole anterior exposed area of the eye, the cornea, the anterior sclera, the conjunctiva, along with the eyelids. So, in order to study Sjogren syndrome in more detail, we have to understand its pathophysiology, that how Sjogren syndrome is, how it's triggered, what is the inciting event, and how it progresses. Now, the exact inciting event in any autoimmune disorder is never known. But there are certain conditions, certain factors that do have certain effect on what is called as the trigger or the incitory event. In Sjogren's syndrome, these are the genetic factors and the environmental factors. Genetic factors can include a variety of different genes. Environmental factors include both the occupational environment along with the diet of the patient. Now, it is not known how the environmental factors can affect, but it is known that the female gender is more affected by Sjogren syndrome than in any other autoimmune disorder. In others, it is usually 4:1 ratio, while in Sjogren syndrome, the ratio is 9:1. The other important thing is, as for the genetic factors, usually the patients with HLA, that is either DR4 or DQ, they are more susceptible for developing the Sjogren syndrome. So whenever we have an accumulation of these environmental or genetic factors, we get a scenario where there is increased excretion and production of autoantibodies against the exocrine glands. Now, as I mentioned earlier, these exocrine glands are the lacrimal glands and the salivary glands. These are the major glands that are affected, but do keep in mind that there are certain other minor glands such as the exocrine glands inside the buccal mucosa, the lingual minor salivary glands. They too are affected, but because they are minor, have small structure, usually microscopic, their infiltration or increase in size is not noticeable. Only the symptomology of the major exocrine glands is usually noticed by the patient and the doctor. So whenever these autoantibodies against the exocrine glands are produced, there is an increased infiltration of lymphocytes. Both B lymphocytes and T lymphocytes start to accumulate and infiltrate the tissue of these glands. As a result, glands start to both increase in size and also start to have reduced activity. Now, along with this, the B lymphocytes that have infiltrated these glands also start to show hyperreactivity. So this begins again a vicious cycle where there's an increased infiltration of B lymphocytes inside the exocrine glands, and then they show hyperreactivity, which produces antibodies. Autoantibodies then again cause further infiltration, and this cycle goes on and on until the patient has more severe symptoms. So both of these particular scenarios result in the dysfunction of the glands and the destruction of the tissue. So when they are dysfunctioned and there is the obliteration of the tissue, we have four distinct scenarios. One, there is decreased tear production. That is due to the infiltration and dysfunction of the lacrimal gland. Lacrimal gland is the gland that produces both the tears and the tear film that is found on the outside of the eyes. Its function is both to protect the eye and to lubricate it, as to facilitate both the vision and its clarity. But as the exocrine gland and the lacrimal gland is just functioning, there is reduced tear production, and the tear film loses its function, and eyes are more prone to dryness. Then we have decreased saliva production. Now, this is due to the decreased functionality of all three salivary glands, the parotid, submandibular, and sublingual. We also have decreased mucus production, and this mucus production is noticed not only in the oral cavity but also in the oropharyngeal and laryngeal cavity, and can even extend into the trachea. So when all of these small glands inside the mucous membrane, they are dysfunctioned, they loses their ability, dryness of that particular area starts to happen. Another is that there is decreased sebum production. Sebum is a lipid containing secretion which is secreted by the sebaceous gland. Now these sebaceous glands are found on the skin and are a part of the appendages of the skin along with hair follicles, among other things. So whenever there is an exocrine gland dysfunction, we have reduced tears, we have reduced saliva, we have reduced mucus production inside the mucous membrane of the oral cavity along with the pharyngeal and laryngeal cavity, and there is decreased sebum secretion on the skin. Next, we'll study about Sjogren syndrome and its associated diseases. Now, a Sjogren syndrome without any associated disease is called a primary Sjogren syndrome. But when it is secondary to any other disease, usually it is also an autoimmune disease, it's called as a secondary Sjogren syndrome. And secondary Sjogren syndromes are about 1/3 of all patients. So if we study their epidemiology, the primary Sjogren is about 2/3 of all patients, and secondary Sjogren is about 1/3 of all patients inflicted with this autoimmune disorder. One of the most common disorders which are associated with it are the rheumatoid arthritis, the systemic lupus erythematosus, the scleroderma, the mixed connective tissue disease, primary biliary cirrhosis, and vasculitis. As you can see, all of these are autoimmune disorders. And these autoimmune disorders, because they share the same pathophysiology, only the type of antibody that is produced varies among them. So, Sjogren syndrome is more than 30% found with other disorders. Next, we're going to talk about the clinical manifestations of the Sjogren syndrome. The primary and the most important one is the diminished lacrimal function, that the ability of the lacrimal gland to produce tears, that is totally diminished, totally decreased. Then we have the mucosal dryness, because all of the small mucosal glands inside the oral cavity, they are destroyed. There is mucosal dryness. Then we have xerostomia, or the dry mouth. That includes the dryness of both the buccal membrane, the tongue, the palate, the hard palate, the soft palate, and leading up to the uvula into the pharyngeal and laryngeal cavity. Then we have difficulty in swallowing. Now, because during the act of digestion, the first step is chewing, where the food is mechanically broken down into smaller portions, into a bolus, and then swallowed into the stomach. Now, because of the dryness, the bolus is not formed. And even if it is formed, because there is no lubrication, the patient is unable to swallow the food into the esophagus. And this may result in irritation, this may result in pain, and can even result in complete inability to swallow food. Another one is the inability to speak. Like I said, xerostomia can extend up to the laryngeal cavity, and the laryngeal cavity contains the vocal cords. Now, if there is dryness of the vocal cords, they start to inflame. They lose their function, and the patient starts with hoarseness, then starts to lose its ability to produce sound. And this is all because of the dryness of the laryngeal mucosa and the inflammation that comes with the vocal cords. Then we also have a burning sensation. Now, this burning sensation is usually felt on the hands, especially the fingertips, and it is due to because we lose the protective effect of the sebum on the skin. Now, because the sebum is not there on the hands to protect it, the changes in the temperature are more felt by the free nerve endings. So the patient usually has what he or she describes as a burning sensation on the hands. Next, we have increase in dental caries. So increase in dental caries or infections inside the teeth is a direct result of the dryness of the mouth, because the mouth is now dry. It is more prone to have bacterial growth inside it, and because these bacteria are usually opportunistic, they sometimes can form caries and infect both the teeth and the gums. A dry mouth can also cause problems in wearing dentures, from wearing dentures that correct the alignment of the teeth to simple crowns. Because dentures require lubrication to hold their place, a dry mouth is not a place for dentures to be applied. It may cause pain, it may cause irritation, and the end result will not be optimal for the patient. So, any kind of dental procedure is usually withheld unless the dryness of the mouth is either cured or taken care of. Then we have the easy fatigability, again because of the dryness of the mouth and low diet of the patient. Some patients can exhibit signs of fatigability. Now, because it's an autoimmune disorder and because there's hyperreactivity of the B lymphocytes, this can also result in increased production of certain interleukins such as interleukin 6 and 18, and these can cause fever in the patients. And this fever is usually of low grade persistent type. It is persistent, steady, and low grade. Another manifestation is what is called as Raynaud's phenomena. Raynaud's phenomena is a condition where the fingertips of the patients first turn white, then turn either red or blue, and then return to normal. Primary Raynaud's phenomena is a normal physiological response to cold. But secondary or pathological Raynaud's phenomena is usually found in autoimmune disorders, particularly those which either have some kind of infiltration or have some kind of vascular element or component to them. So, because of this, there is a constriction of vessels in the distal part of the extremities. This causes first the blanching or the whiteness to the appear, and then after the blanching, the blood rushes in, causes a red appearance, and then when the blood pools in, blueness or blue discoloration starts to appear. And as the spasm reduces, normal blood flow is resumed, it is slowly vanished. So, a Raynaud's phenomena is usually found in Sjogren syndrome. Then we have the myalgias. Again, myalgias only have to do because it's an autoimmune disease. It is not usually seen, it's an uncommon symptom, but it should not be disregarded and should be kept that it is part of the symptomology of the Sjogren syndrome. Then we have the arthralgias and non-erosive arthritis. Both the arthralgias and non-erosive arthritis are again because of the autoimmunity, and because the autoimmunity in Sjogren's is slow, progressive, and is accompanied by inflammation. And because of this, patients usually have inflammation in their joints because the joints move a lot, have a lot of friction rubbed to them. So there is pain in the joints along with arthritis where the bone is non-erosive. Next, we're going to talk about the physical examination of a patient suffering with Sjogren's syndrome. Now, with physical examination, one of the pathognomic symptom or sign that we see is the atrophy of the filiform papilla on the tongue. Now, the filiform papilla are small, thin protrusions or appendages on the tongue. And whenever there is infiltration of the exocrine glands, of the minor exocrine glands inside the oral cavity, the first sign that appears is the loss of these papillae. Now, these papillae are the first one to atrophy because the infiltration causes both the dryness and the destruction of the superficial layer or the epithelium. Now, because the superficial layer starts to destroy, the papillae or the filiform papillae are the first one to atrophy or disappear, and they can be easily be seen on a normal throat examination during a physical evaluation. Another one sign that can be seen on a physical examination is the enlargement of the parotid gland. As I mentioned earlier, parotid gland is the largest salivary gland. It is also the gland that can be felt with physical examination, as the other glands are hidden. One is underside the mandible, the other one is underside the tongue. So they are not easily palpable with physical examination. But parotid gland being around the temporomandible joint is easily palpable. And whenever a patient is suffering from Sjogren syndrome due to the infiltration of the lymphocytes, there's an increase in the size of the parotid gland, and that can be easily seen and palpated on the physical exam. Next, we're going to talk about ocular manifestations in Sjogren syndrome, and these are very important. Now, whenever there is some kind of ocular manifestation in this syndrome, the patient usually complain that their eyes are very sticky, they are unable to blink, and they have a very characteristic sandy or gritty feeling whenever they try to blink or close their eyes. Another component is that they also complain of burning in on their eyes, and this burning is due to because when there are no tears and there are no tear film to protect the anterior of the eye and the cornea, all the dust and other particles which should have been eliminated by the tear film start to accumulate on the sclera and the cornea. This results in first irritation and, if prolonged, results in burning sensation on the eyes. Next is the accumulation of the secretions. Now, because there are no tears, other secretions produced by the conjunctiva and the glands around the eyelids and the hair. Now, these secretions start to accumulate in the conjunctiva, and they also start to concentrate, and because of their concentration, the patient usually complain of the stickiness in their eyes. And because there are no tears to dilute them and to spread them evenly on the eyes, we have this particular, sometimes even toxic accumulation of secretions. Next, decreased tearing. Again, because there is lacrimal gland is dysfunctioning, tears are not easily produced. Then we have the redness of the eye or the sclera. Now, this is again because all the dust particles and other particles that should have been eliminated by the tears do not wash down. Instead, they remain at their place. First, they cause itching, burning. If continued, they cause inflammation at that particular side. And due to the inflammation, we see the redness of the sclera. Then we have the itching. Again, because of the inflammation and redness of the sclera, patient usually also complain of itching. Then there is eye fatigue. Now, tear film not only protects the eye, it also helps in blinking. So if the blinking action is hindered by the dryness of the eye, patients or the muscles or the ocular muscles that are involved in the blinking have to push more, and because of this they are prone to easy fatigability, and because of this patients usually complain of eye fatigue. There is also an increased photosensitivity. This increased photosensitivity is again due to the inflammation and redness of the sclera. And all of these signs and symptoms are collectively termed as keratoconjunctivitis sicca. Now, keratoconjunctivitis sicca can occur in isolation without Sjogren syndrome, or it can occur as a component of Sjogren syndrome along with dry mouth and the infiltration and hyperreactivity of the lymphocytes. Next, we're going to study about the exocrine manifestations. Now, these exocrine manifestations, again, they manifest as there is less mucosal secretions because the minor mucosal glands dysfunction. There is dry nose because the mucosal glands inside the nose lose their ability to secrete and lubricate the nose. Because of this, the nose starts to dry, and for some, there is even epistaxis or bleeding from the little's area in the anterior part of the nose. Then it can even result in pancreatitis because, like I said, it attacks the exocrine glands. And pancreas is a mix of both exocrine glands and endocrine glands. So, if Sjogren syndrome is complicated and chronic and it is not treated, sometimes its effects can even reach the exocrine glands of pancreas, reaching in its inflammation and producing pancreatitis. Then, because there's less mucosal secretion, we have dry mouth or the dry throat. Then we have the atrophic gastritis. Now, atrophic gastritis is again because of the obliteration of the exocrine glands inside the lining of the stomach. Because those glands are destroyed, the normal mucosal membrane of the stomach, because of the acidity, is totally obliterated, and because it is totally destroyed, the stomach lining starts to have an atrophic effect. And because of its atrophic effect, both the ability of the stomach to produce the protons, the chloridines, the HCl, in other words, the pepsin, all of its ability is completely destroyed. So the effect of stomach in the digestion is severely hindered. Next, we have dyspareunia. Dyspareunia is described as the dryness of genitals or the genital area. As I mentioned before, the exocrine glands also contain or also have some kind of decreased secretion of sebum, because these antibodies in Sjogren syndrome also attack the sebaceous glands of the skin that produce the sebum. And because there's less sebum being produced, not only there is less sebum on the face and the hands, but all of the oily nature and the lubrications that is formed around the genitals and inside them is totally gone. And this particular condition is what is known as dyspareunia. Then we have dry trachea, or also called xerotrachea. Again, like I said, if dry mouth or the extent of the obliteration of the minor exocrine gland extends way further than the pharyngeal and laryngeal cavity, it can even cause the destruction of the mucosal exocrine glands inside the trachea, resulting in a dry trachea or xerotrachea, and it is usually manifested as chronic dry cough for the patient. Next, we have the ocular manifestations with their diagnostic evaluation. Now, In order to diagnose a patient with Sjogren syndrome, there are usually three tests that we usually perform. Now, it can be established on the physical exam that the patient has keratoconjunctivitis sicca or simply dry eyes. But if the patient has Sjogren syndrome or just simply keratoconjunctivitis sicca, it can be distinguished by certain tests such as the Schirmer 1 test, which is a test which measures the ability of the lacrimal gland to lubricate the eye. And it is done via placing a filter paper in the lower eyelid and measuring how much it has moistened. Then we have the tear break time test, or in other words, how much tear is produced periodically. If the break between these tests, is it prolonged, is it totally gone, or if there are some frequent breaks. Whatever the case is, if these breaks are prolonged, we can easily say that this patient is diagnosed with keratoconjunctivitis sicca and in turn Sjogren's syndrome. Then we have the tear lysosome content test. One of the tests to confirm the diagnosis of Sjogren's syndrome is the tear lysosome test, because in this test we measure the composition of the tears. Now, in normal conjunctivitis sicca, the composition remains constant, only the quantity of the tear formation is decreased. But in Sjogren syndrome, because of the infiltration of the lymphocytes, its composition is also altered. So in this test, we can easily differentiate between simple dry eyes and Sjogren syndrome. Another way that we can examine is by a slit lamp examination, because during sicca syndrome, not only the sclera is hurt and inflamed, but the cornea of the patient is also sometimes damaged, and that damage results in what is called as corneal ulcers. And corneal ulcers can be visualized by a specific stain called the rose-bangle stain or by a fluorescent stain. By using either one of these stains, we can easily identify if the cornea of the patient is intact or if there is some ulceration. And this ulceration, by using the staining method, is then examined via the slit lamp examination. Next, we're going to study about the pulmonary manifestations in Sjogren syndrome. So, a patient with Sjogren syndrome usually presents with a chronic dry cough. Now, this dry cough is usually due to dry trachea or xerotrachea, which I mentioned earlier, which is due to the extent of the Sjogren syndrome into the larynx and even the trachea, and this causes the exocrine glands and the mucosal glands of the trachea to get destroyed. This results in easy irritability for the patients while inhaling and resulting in a dry cough. This dry cough is also without any sputum. This is also because no mucosal glands are producing any sputum. Next, we are going to study about the renal manifestations of the Sjogren syndrome. Now, the renal manifestations are usually localized, and because of the infiltration of the lymphocytes, and this infiltration usually results in interstitial nephritis. When the infiltration is in the interstitium, it can even express itself as hypostenuria or diluted urine, because the nephrons of the kidneys are unable to concentrate the urine. It can even exhibit itself as renal tubular dysfunction, where the tubules of the nephrons lose their ability for both the excretion and reabsorption. And because of this dysfunction, we get a condition which is usually termed as renal tubular acidosis. And this renal tubular acidosis results in the acidic environment inside the cortex and the medulla of the kidney, resulting in both diluted urine and highly acidic. Now, if this condition is given full extent, it can even result in nephrocalcinosis. Usually, calcium is deposited in the pelvis of the kidney, forming calcium stones. But in Sjogren's syndrome, due to the infiltration of the lymphocytes, what we get is deposition of calcium in small quantities along the whole of the cortex, and this is termed as nephrocalcinosis. Now, if nephrocalcinosis and acidosis and tubular dysfunction result together, this can result in inflammation of the whole nephron along with the glomerular apparatus, resulting in glomerulonephritis. Now, this glomerulonephritis can even occur as cryoglobulinemia, whereas the cryoglobulins are more found in the blood. And this can even give way to systemic lupus erythematosus. Next, we're going to talk about the extraglandular manifestations of the Sjogren syndrome. Now, these extraglandular manifestations are arthralgias, that is the pain in the joints. It can be Raynaud's disease, that is the blanching and then the bluish discoloration of the extremities of the hands. It can even result in lymphadenopathy or the swollen lymph nodes, which are usually found due to the inflammation of the parotid and other salivary glands. It can even occur as lung involvement, as I mentioned previously, due to a dry trachea resulting in chronic dry cough. It can even occur as a vasculitis. It can even occur with kidney involvement resulting in from glomerulonephritis to renal tubular acidosis. It can even occur as simply glomerulonephritis. Now, sometimes Sjogren syndrome can even affect liver, and liver's involvement can be seen as lymphomas forming in and around the lymphatic tissue. Now, these lymphatic tissue are particularly found in the pharyngeal cavity along with tonsils and the adenoids. And lymphoma formation is one of the more severe complications of the Sjogren's syndrome. Next, we have the peripheral neuropathy. Peripheral neuropathy again can occur due to some antibodies attacking the free nerve endings, resulting in neuropathic pain. And last but not the least, some patients even exhibit myositis or the inflammation of the muscular tissue. Next, we are going to talk about the antibody manifestations. As I mentioned earlier, the antibodies that are produced in the Sjogren syndrome are the anti-Rho or the anti-SSA and anti-La or the anti-SSB antibodies. But sometimes other antibodies also start to being produced, and this can result in symptomology of some other conditions. So one of these antibodies is the anti-centromere antibody, which can result in scleroderma type symptomology and pathogenesis along with Sjogren syndrome. Sometimes there's anti-mitochondrial antibody, and this antimicrobial antibody targets the parenchyma of the liver, and because it targets the liver, it results in biliary cirrhosis. One of the other autoantibody that is produced is 21 hydroxylate autoantibody. And this particular antibody targets a particular enzyme that is found in the adrenal gland, that is the suprarenal gland of the kidneys. This results in both blunted and abnormal adrenal response, as the all three layers of the adrenal glands produced either very low or none at all hormones. Next, we're going to talk about Sjogren syndrome and its nervous system manifestations. And usually, the only nervous system manifestation that we find in a patient with Sjogren syndrome is myelitis, that is, the inflammation of the spinal cord. And this results in usually symptomologies ranging from hemiplegia to simple mild discomfort. Next, we're going to study about lymphoma manifestations. The formation of lymphoma is one of the more complicated and morbid manifestation of the Sjogren syndrome. But its manifestation usually results in few signs and symptoms such as leukopenia, that there is low white blood cell count in the blood. There's cryoglobulinemia, that cryoglobulins start to increase in number in the blood. Then we have purpura. Now this purpura or purpur discoloration on the skin is again due to low platelet counts and the autoantibody nature of the Sjogren syndrome. We sometimes also see low C4 complement level, that again is consistent with it being an autoimmune disease. Next, there's parotid gland enlargement. Now, this parotid gland enlargement usually goes hand in hand with formation of lymphoma. Next, we're going to study about the diagnosis of the Sjogren syndrome, and it can be diagnosed via laboratory tests. But in laboratory tests, we usually get elevated erythrocyte sedimentation rate, which is usually non-specific. We also get anemia, but that anemia is both normochromic, that there is no loss of hemoglobin, and normocytic. The size of the RBCs are also normal. So the cause of anemia is usually hemolytic. Now, these laboratory tests are both non-specific and non-confirmatory for Sjogren syndrome. In order to confirm its diagnosis, we usually perform biopsy of minor salivary glands. And usually the minor salivary glands that are biopsies are labial salivary glands, which are usually found around the corners of the lips and the oral cavity. And on this biopsy, if we find lymphocytic infiltration, it gives confirmation that this patient is suffering from Sjogren syndrome, as opposed to fibrosis or the infiltration of fibrocytes, which is usually found in scleroderma or systemic scleroderma. Next, we have diagnostic tests for Sjogren syndrome, which are done but can give us some view and extent of how much the disease has progressed. One of them is cylometry, where we measure how much saliva the patient is producing. And the volume of the saliva that the patient produces gives us some rough idea that how much infiltration and dysfunction of the salivary glands have taken place. Next, we can perform a xylography. We introduced a contrast media to measure both the ducts of the salivary glands and the tissue and the excretion pathway of the saliva. Now, this can also give us how much infiltration has taken place and if there's any blockage in the excretion of the salivary glands, as opposed to having Sjogren syndrome. We can also perform scintigraphy, where we attach a radioisotope to a drug and then use the radiations released by that radioisotopes as it is metabolized by a particular organ. Here we use radioisotopes that are metabolized in the salivary glands and then use the gamma camera to study them. It is not a routine procedure that is done, and it is slowly being replaced by more convenient, quick, easy, and less dangerous methods. Now, one of those methods is among the imaging techniques. We can even perform ultrasounds to see if the parotid glands, submandibular or the lingual and the lacrimal glands, if these glands have any kind of infiltration, change in the tissue density, or any kind of change in their hypo or hyperechoic nature. We can also perform an MRI to see if the infiltration is only localized to the exocrine glands or if it is extra exocrine and the infiltration is also happening inside the lymph nodes or maybe some other structures. Next, we can even perform magnetic resonance psilography. Now, in today's age, magnetic resonance psilography is taking place of the old diagnostic tests such as psilometry or psilography or the radioisotope study because it is both sensitive, it is very specific, has huge amount of contrast and definition. So Sjogren syndrome and differential diagnosis can easily be confirmed on this magnetic psilography. Among other things, it is also very safe as no radiation is used. Next, we're going to study about the differential diagnosis of Sjogren syndrome. And as Sjogren syndrome usually exhibits sicca symptoms such as dry eyes, dry mouth, and bilateral parotid enlargement, we're going to study what other diseases can also cause these symptoms. So we're going to start with xerostomia or the dryness of the mouth. Now, dryness of the mouth is also found in viral infections such as Epstein-Barr virus infection. It is also found in administration of certain drugs and medications. It is like psychotherapeutic drugs, parasympathetic drugs, antihypertensive drugs. All of these can have side effects, that is the dryness of mouth. Then the dryness of mouth can also have a psychogenic origin, that it is the brain, the nervous system that is giving the signal to the exocrine glands not to produce saliva, and it is usually found in patients with space occupying lesions. During irradiations, usually as part of radiotherapy in patients with cancer, can also exhibit signs of xerostomia. Patient with diabetes mellitus also have dry mouth. Sometimes trauma can interfere with the excretion of saliva of the salivary glands, that the duct is both traumatized and damaged, resulting in low secretion of saliva and dry mouth. Sjogren syndrome is also a part of the differential diagnosis process, and it is a diagnosis of exclusion. And amyloidosis sometimes also exhibits signs of dry mouth. Next sicca symptom that we're gonna study is the dry eye. Now, dry eye is usually found among these four categories for its differential diagnosis. It can be found as inflammatory diseases, in toxicity, in neurological conditions, and in other. Now, as for inflammatory diseases, it can be Steven-Johnson syndrome, it can be pemphigoid vulgaris, it can be chronic conjunctivitis, chronic blepharitis, that is the inflammation and infection of the eyelids, or again, it can be the Sjogren syndrome. Next, we're going to study of the toxicity. Now, the toxicity that can result in dry eyes can be due to the burns, especially the second and third degree burns, and certain drugs. Some of those, as I mentioned earlier, can also result in dry eyes as well as dry mouth. Next, we're going to study about the neurological conditions such as impaired lacrimal gland function due to low nervous stimulation and impaired eyelid function that can hinder in the release of the tears. As for miscellaneous, it can be trauma to the both the lacrimal duct or the salivary duct, inhibiting the excretion of saliva or tears, or it could be hypervitaminosis A, it could be blink abnormality due to neurogenic causes, it can be even be eyelid scarring, it can be anesthetic cornea, or even epithelial irregularity causing the dry eye. Now, the next sicca symptom is the bilateral parotid gland enlargement. Now, it can be due to viral infections, sarcoidosis, metabolic disorders, and even endocrine disorders. As for viral infections, it can be due to mumps, which is more common in children. It could be due to influenza. It can be due to the Epstein-Barr virus. It can be even due to the HIV or hepatitis C virus, and even due to the relatively unknown virus known as the Coxsackie A virus. Now, as for sarcoidosis, the IG4 syndrome and Sjogren syndrome can also cause bilateral parotid swelling. The metabolic disorders that can cause such swelling are the diabetes mellitus, hyperlipoproteinemia, chronic pancreatitis, and hepatic cirrhosis. As for the endocrine disorders, acromegaly and gonadal hypofunction can both cause bilateral parotid gland swelling. Now, these were the differential diagnoses of the sicca symptoms or various symptoms of Sjogren syndrome. Here, we will have differential diagnosis regarding various diseases which follow the same symptomology as the Sjogren syndrome. Now, these are the HIV infection along with the sicca syndrome, Sjogren syndrome, and sarcoidosis. Now, for HIV infection, it is usually in young males. For Sjogren syndrome, it is usually in middle-aged women, while sarcoidosis has no such epidemiology. It occurs in patients of every age and gender. Now, for autoantibodies, both the HIV infection and sarcoidosis, being non-autoimmune disorders, lack any autoantibodies, while only Sjogren syndrome contains autoantibodies. Now, for the infiltration, both the HIV and the Sjogren syndrome have lymphatic infiltration. Only the difference is in HIV infection, the infiltration is by CD8 cells, while in Sjogren syndrome, it is by the CD4 cells. While in sarcoidosis, there is no lymphatic infiltration, only granulomas form in the salivary glands. Next, we'll talk about the association. HIV has association with human leukocyte antigen DR5, while Sjogren syndrome have association with HLA DR3, DRW52, while sarcoidosis has no known association with HLAs. Lastly, HIV infection will be positive for serological markers for HIV, while the Sjogren syndrome and sarcoidosis will be negative for any HIV serological markers. Next, we'll study about the treatment of the Sjogren syndrome. The treatment of Sjogren syndrome is divided into two: the glandular manifestations and the extraglandular manifestations. The glandular manifestations again are the dry eyes, the dry mouth, and the enlarged parotid glands. For dry eyes, we advise the patient to avoid smoking areas, to avoid the windy, low humidity areas, and to avoid any anticholinergic and diuretic medicine, as they all cause side effects of dry eyes. Now, as for the local stimulation, we advise the patient for artificial tears without preservatives, such as methyl cellulose artificial tears. Sometimes we even give bicarbonate buffered electrolyte solutions, which can act as artificial tears. Now, for local stimulation, for dry eyes, we give cyclic adenosine monophosphate solution along with sometimes cyclosporin 2% solution in olive oil. For systemic stimulation for the dry eyes, we give pilocarpine 5 milligram 3 times a day, or sometimes even cevimetin 30 milligrams 3 times a day. As for the surgical options, we can even occlude the nasolacrimal duct. Now, this occlusion causes the tears and the tear film to be contained inside the eye, so as they do not drain into the nose. And even if the lacrimal gland is producing very few tears, they remain in the eye and lubricate it, because the drainage system has been occluded. Another advice that can be given is the application of soft contact lenses to protect the cornea, and corneal transplantation in case if the patient is suffering from extensive corneal ulceration, making him unable to see anything. Now, as for the dry mouth, we advise the patient for complete oral hygiene after every meal, including brushing, tongue scrubbing, and flossing. As for the local stimulation, local application, we give the topical application of the fluoride to boost the antibacterial properties of it. As for the local stimulation for the dry mouth, we advise sugar-free flavored lozenges and gums, because chewing these gums and lozenges can have a mechanical localized effect on the salivary glands to produce more saliva. As for the systemic stimulation, it is the same as the dry eyes. We give both the pilocarpine and the cevimeline. Next, we can also give topical statin drops and colimethrazole lozenges. These colimethrazole is an antifungal agent in case the corneal ulcers have fungal infection, or topical nystatin if we suspect the corneal ulceration is moving towards fungal infection. As for enlarged parotid glands, we advise the patient first and foremost hot fomentation, that is localized wet heat. Now, localized heating can have extremely good effects in managing the swelling and enlargement of the parotid glands. We also give patients antibiotics, sometimes prophylactically, so the swelled or the enlarged parotid gland does not become infected. We also give analgesics in order to treat any pain related or neuralgia related to the enlargement of the parotid glands. We also rule out lymphoma. Now we have to rule out lymphoma because if the lymphoma is present and we have some confirmation via biopsy, our treatment plan changes drastically. It changes completely. So we have to rule out if lymphoma is present in the parotid glands. Now, as for the extraglandular manifestations, it could be arthritis, Raynaud's phenomena, renal tubular acidosis, vasculitis, or lymphoma. For arthritis, we give hydroxychloroquine 400 to 200 to 400 milligram per deciliter or methotrexate 0.2 to zero point 0.3 milligram per kg body weight weekly, along with daily prednisolone or glucocorticoids. They are usually given in a dose less than 10 milligrams daily and orally, and they're usually enteric coated in order to avoid any dyspepsia. As for the Raynaud's phenomena, we advise the patient to protect her or himself from the cold, and that protection can be by not exposing the hands to the cold or to the cold water and wearing gloves to keep the circulation going on and to warm them up. As for the renal tubular acidosis, the first choice of treatment is giving bicarbonate infusions. Now, these bicarbonate infusions neutralize the acidity that is found inside the tubules of the nephrons, and we can reduce and even take care of the renal tubular acidosis. As for the vasculitis, it depends upon the what kind of vasculitis is present. Is it small vessel, medial vessel, or large vessel? Depending upon which vessel it is, its treatment changes, but we give the standard regimen. As for the lymphoma, we give chemotherapy regimen known as CHOP or the cyclophosphamide vincristine prednisolone regimen along with an anti-CD20 antibody. Now this regimen can cure lymphoma, and lymphoma is one of the few cancers which have very high rates of remission. So, in this lecture on Sjogren syndrome, we studied what Sjogren syndrome is, which different symptoms comprises it, what is keratoconjunctivitis sicca. We also learned its various manifestations, from its pulmonary manifestation to its other manifestations. We even studied its differential diagnosis based on both the symptoms and different diseases. Then we learned about its treatment plan, both the granular and the extragranular treatment plans. So this was the lecture on the Sjogren syndrome. Thank you so much for watching sqadia.com.